I don't think aromatase inhibitors are the devil. Vigorous Steve here. Let's talk about aromatase inhibitors, which seem to be demonized as of late by a lot of dogmatic people in our bodybuilding community or TRT space, saying that aromatase inhibitors should never be used under any circumstances because they're so toxic, causing all kinds of side effects in the short term and in the long term. Now, I don't agree with this in any way, shape, or form. I feel that there's a huge difference between aromatase inhibitor abuse, where serum estradiol levels are chronically crushed down to the single digits or undetectable levels. And there's of course also intelligent aromatase inhibitor use, where serum estradiol is remained in the middle or top of the reference range, which doesn't seem to cause the side effects that people generally associate with aromatase inhibitors. So I want to use this video as a little bit of a deep dive while keeping everything concise to show you in which cases aromatase inhibitors might not be beneficial and might cause side effects, and in which cases aromatase inhibitors should be generally benign and suitable for a long-term use, again, assuming that serum estradiol levels are maintained within its clinical reference ranges and maybe slightly over that when serum testosterone levels are, well, maybe undetectably high when you're on cycle, right? But before we get into it, please like the video, leave a comment for the algorithm, and consider joining the Vigorous crew, now almost 51,000 people strong, by subscribing. I think a lot of these dogmatic opinions come from the clinical literature, which is predominantly performed on postmenopausal women suffering from estrogen-positive breast cancers, in which case aromatase inhibitors are prescribed as a treatment for various stages of breast cancers. Sometimes aromatase inhibitors are used as a second-line adjuvant therapy alongside selective estrogen receptor modulators like tamoxifen or raloxifene, for example, when these SERMs have already been used for several years. Again, this is in the early stages of breast cancers, and aromatase inhibitors are also used in cases of advanced estrogen-positive breast cancers that appear to be non-responsive to tamoxifen treatment, where the breast cancer is still progressing. In these cases, aromatase inhibitors are prescribed to crush serum estradiol levels down to zero because postmenopausal women predominantly produce estradiol in adipose tissue, right? After menopause, estrogen production in the ovaries almost ceases down to zero, whereas tamoxifen treatment is generally prescribed for women who have not undergone menopause yet. Before menopause, depending on the phase of the menstrual cycle, the ovaries produce various amounts of estrogens, and in case of an estrogen-positive breast cancer, a selective estrogen receptor modulator needs to be used to block all of the estrogen receptors because there's so many different estrogens present in the body. But post-menopause, when the ovaries don't produce so much estrogen anymore, the conversion of testosterone into estradiol is inhibited with an aromatase inhibitor, like anastrozole, Aromatase, for example, or exemestane, Aromasin, or letrozole, Femara. These aromatase inhibitors are used to crush serum estradiol levels down to basically zero, and this is where a lot of the side effects are coming from. Coincidentally, a lot of these side effects associated with aromatase inhibitors are very similar to the symptoms of menopause. I'm talking about osteoporosis, cardiovascular disease, hot flashes, dry joints, dry skin, muscle pain, right? Myalgias. A lot of the side effects and symptoms of aromatase inhibitors are very, very similar to the symptoms of menopause. And maybe some of you guys have experienced similar symptoms as menopause when you've overdone the use of aromatase inhibitors. Maybe you've done your blood work and your serum estradiol on the ultra-sensitive liquid chromatography tandem mass spectrometry test was only 4 picograms per milliliter. I'm sure you felt horrible. I'm sure you had dry skin. Maybe you've had some hot flashes. I'm sure your libido was gone with the winds, and your HDL was horrible also. Crushing your serum estradiol leads to cardiovascular disease over long periods of time. Not when you crush your serum estradiol for maybe 2 weeks, 3 weeks, leading into a contest. And of course, in that case, you'll be a tad flat, especially when masteron is being used, or you combine that with a diuretic to get extra crispy. Yes, you'll be flat, but again, that's a temporary state. When you're crushing your serum estradiol concentrations for 2 to 3 weeks leading into a contest, you can get out of the flatness with a broad selection of pharmacology that we have at our disposal if you're into bodybuilding competitions. But as soon as you step off stage, in many cases, the intelligent coaches will take all of the aromatase inhibitors out, all of the selective estrogen receptor modulators out, and do a bolus dose of testosterone just to bring the estradiol back up. So we're talking about chronically low serum estradiol concentrations for 2 weeks. 3 weeks at maximum, not the entire year. Not like you see with women suffering from estrogen-positive breast cancers, where aromatase inhibitors are used to crush serum estradiol levels for years. For years, because that's how long it takes for some of these breast cancers to resolve themselves and go into remission. Again, aromatase inhibitors are used to allow estrogen-positive breast cancers to go into remission and prevent the recurrence of breast cancer from returning. So why are we using these side effects, these terrible, terrible symptoms and side effects of aromatase inhibitors in cases where estradiol is chronically low? When us bodybuilders, now that we understand a lot more about estradiol and its benefits regarding cardiovascular health, regarding neuroprotection, regarding its role in the endothelium where it mitigates oxidative stress in a similar sense that vitamin C mitigates oxidative stress in the endothelium and, well, most of other tissues in the body. Estradiol plays a crucial role in collagen synthesis, and it helps to regulate IGF-1 secretion when growth hormone stimulates that in the liver. A lot of benefits of keeping estradiol in the middle to the top of the reference range. And now that you know all of that, with intelligent use of aromatase inhibitors, sprinkling in a little bit to keep levels favorable and prevent serum estradiol levels from going too high, causing side effects like poor erection quality or impaired libido or very emotional states while watching movies, right? You'll keep that between you and your partner. But I'm sure we can all remember a time when a movie hit a little bit harder than usual and you start crying, apparently for no reason. That's because your serum estradiol levels are a little bit too high for comfort. That's why aromatase inhibitors are there to keep your estradiol levels a little bit more favorable and prevent these emotional outbursts from happening and prevent gynecomastia from happening. And there's a lot of side effects which are associated with very high estradiol levels as well as very low estradiol levels, and we use aromatase inhibitors to keep them favorable. Now, this is not to say that aromatase inhibitors should always be used on cycle. They're certainly not mandatory. You can design your cycle in a way that you don't need aromatase inhibitors at all. For example, you go on a low effective dose of testosterone, whatever dose of testosterone you'll need to get a serum estradiol reading of, let's say, 40 picograms per milliliter. That's at the top of most clinically recognized reference ranges. Some are 40, some are 44, some go even a little bit higher. You go on an effective dose, so let's say 200 milligrams testosterone enanthate per week. And if you like cypionate, well, by all means, go with cypionate instead. A low dose of testosterone giving you a very high, but within range serum estradiol level. And then you add in the other anabolics on top. If you add in nandrolone, for example, which acts as a cofactor in the aromatization of testosterone into estradiol, that 200 milligrams of test E or CYP might convert into 50 picograms per milliliter. So now you either need to reduce the testosterone dose from, let's say, 200 to 150 to keep this serum estradiol level favorable, or you need an aromatase inhibitor. Again, if you don't want to do that, you might want to look into primobolan, masterone, boldenone, dihydroboldenone, or other compounds which are known to reversely bind to the aromatase enzyme and temporarily prevent the conversion of testosterone into estradiol. So when you go in a combination of test and nandrolone, aromatization might go up. But if you go in a combination of test and primo, or test and boldenone, or test and masterone, or test and dihydroboldenone, aromatization might go down. So that 200 milligrams of testosterone enanthate might convert less, and you're ending up with a serum estradiol concentration of 25 picograms per milliliter. Now, that might force you to increase the testosterone dose, right? So intelligent cycle design is always alongside blood work. But it's the blood work that ultimately determines if you can get away without the use of an aromatase inhibitor. With that being said, let's look at the total picture for a chance, not this dogmatic nitpicking of one study or a couple studies which show the most deleterious health effects of one compound, when in reality, in bodybuilding or in fitness, the TRT space, we don't just take one compound. We take a multitude of compounds. Some are there for the benefits, and some are there to mitigate some of the side effects of the compounds that we take for their benefits, but we don't want the side effects. That's why we have these ancillaries in place to keep us healthy or prevent side effects from manifesting, one of which being the aromatase inhibitors. Let's take a step back. Let's say you have access to all the drugs that you want, but your body doesn't respond well to all of the drugs that we can choose from. Let's say your short list is only test, primobolan, anavar, and a couple peptides, right? A couple peptides. Well, this is my short list. Already made a video about that. I'll link it at the end of this one. Let's say you don't want to run primo year-round, right, to control your serum estradiol levels. Let's say you want to go on a nice, fat, juicy cycle of test only. You go and test an aromatase inhibitor to control estradiol because you don't want high test and a ton of gynecomastia, or high test and a ton of acne, or high test and a ton of water retention, right? You use an aromatase inhibitor intelligently, keeping serum estradiol levels favorable, perhaps slightly over the reference range, just to prevent side effects from manifesting. It's a reasonably cheap cycle. It shouldn't cause tremendous side effects when you're comparing a similar dose or similar anabolic response of a combination of test and primo. We'll take myself as an example. I'll list the blood work down below. With similar estradiol levels, on 1,000 milligrams of test and 1,000 milligrams of primo per week, a very hefty dose, a bodybuilder dose, my lipids were worse compared to 1,720 milligrams testosterone with an aromatase inhibitor in the form of aromasin. So now we have similar anabolic androgenic steroid intake, albeit a few years apart again, so I got a couple years older, doing similar things for lipid management, right? We're doing the fish oil, we're doing the citrus bergamot, we're doing the daily fasted cardio, the ketogenic diet is the same, but the drug selection is different. Both similar caloric intake. My lipids are worse on a combination of testosterone and primobolan compared to a combination of testosterone and aromasin to control estradiol levels. Estradiol levels are very comparable, but the HDL is worse when adding in the primobolan. Right? You have to look at the total picture, not just a wishy-washy study performed on postmenopausal women crushing their serum estradiol levels with an aromatase inhibitor, because that's not what we're doing here. We're trying to control it, not crush it. While we're on the subject of cardiovascular health, there's a very good study, a cohort study that you can read. It's very recent. It's titled Aromatase Inhibitors and the Risk of Cardiovascular Outcomes in Women with Breast Cancer, a population-based cohort study. I'll link it down below. This is a very good study to show the deleterious effects of aromatase inhibitors when it comes to heart failure or cardiovascular mortality compared to tamoxifen. Again, keep in mind that tamoxifen and selective estrogen receptor modulators have some pro-estrogen-like effects, especially when it comes to cardiovascular health. In the context of estrogen-positive breast cancers, estradiol levels are crushed with aromatase inhibitors, worsening cardiovascular health. That's not what we're trying to do. We're just trying to keep estradiol levels favorable. So ideally, we look into studies of aromatase inhibitor use in men. And luckily for us, there's a very lengthy and in-depth review paper titled Aromatase Inhibitors in Men, Effects and Therapeutic Options, which investigates just that. The use of aromatase inhibitors in men regarding their effects on bone mass and bone mineralization in various medical settings, when aromatase inhibitors are used in adolescent men to increase their height, or used as a single-line treatment to increase testosterone production by raising LH and FSH concentrations. This review paper showed that there were no deleterious effects of using aromatase inhibitors in men regarding bone mass or bone mineralization, assuming that serum estradiol levels were not crushed. Again, in these particular medical settings, it's not necessary to crush serum estradiol concentrations, maybe reduce it a little bit to prevent negative feedback on the hypothalamus and pituitary, allowing for the most amount of LH and FSH secretion, or in the case of TRT, allowing serum estradiol levels to stay favorable for all of its beneficial effects on health and, of course, libido, which is one of the reasons, the main reason why men lean towards TRT. In this case, serum estradiol levels was not crushed, bone mass, bone mineralization was not affected. This review paper does point out that there's no long-term data, and bone mineralization might still be a concern with long-term use of aromatase inhibitors, because osteoporosis is such a major concern when aromatase inhibitors are used to combat estrogen-positive breast cancers in postmenopausal women. Same compound, different scenarios, different outcomes, because estrogen is crushed in one scenario and it isn't crushed in the other one, right? Keep that in mind. Crushing estrogen is where a lot of these side effects and a lot of the deleterious effects associated with aromatase inhibitors are coming from. Last very important thing, actually two things. Let's start there. Using aromatase inhibitors can accelerate hair loss, right? We have to mention it here. I don't think it's a very life-changing event, and hair loss is going to manifest as you age, as am I experiencing a little bit of a hair loss that I'm getting older and older and older, and of course I'm using a DHT derivative, which I'm sure is accelerating the hair loss. Let's say you use an aromatase inhibitor, which prevents the conversion of testosterone into estradiol, or it reduces it in the scalp, where there's a lot of 5-alpha reductase activity. Now you have higher testosterone in this tissue, which can then convert into DHT at a higher rate, inducing more hair loss. You can look into finasteride or dutasteride with the same reasoning. You use testosterone, you use a 5-alpha reductase inhibitor, preventing the conversion of testosterone into dihydrotestosterone, and now this increased level of testosterone in the scalp can convert into estradiol at an accelerated rate, resulting in gynecomastia or water retention or acne, right? So are you going to have to use both if you don't want hair loss or gynecomastia? There's something to say no matter which way you look at it. I want to mention it here, but if you're suffering from either or, there's always a method to combat the side effects. Most people don't suffer from both. So men either suffer from hair loss or gynecomastia, or acne and hair loss, or acne and gynecomastia, but usually not gynecomastia and hair loss. And if that's the case for you, well, maybe you should pick up chess. Yeah, because that's going to be a lot of ancillaries and a lot of management just to run a little bit of tests. And well, if that's the unfortunate case for you, there's always the nandrolone only cycle, but you might still need to supplement a little bit of estradiol to keep estradiol levels somewhat favorable, or supplement DHEA, which ultimately converts into estradiol. But right, if testosterone is your enemy, you don't even want to take a DHEA or ACG just to keep estradiol levels somewhat favorable. You might have to go with estradiol valerate or ethinyl estradiol coming from birth control. Right, we'll save that from a different video. I don't think it's a suitable approach. But right, it might be the last line in defense for people who still want to make that their sweet gains. I think a very valid point of discussion and important to bring up at the end of this video is neurotoxicity. Testosterone, trenbolone, winstrol, and many of the anabolic androgenic steroids have been associated with neurotoxicity. Now, some of this is coming from excitotoxicity, which is a complex process where the glutamate receptors are activated by testosterone or other anabolic androgenic steroids, which ultimately lead into neurodegradation and neuronal cell death. On the positive side, the brain also contains aromatase enzymes allowing for the conversion of testosterone into estradiol, and it's this estradiol that offers neuroprotection. So by converting testosterone, which is excitotoxic, causing neurodegradation, converting the testosterone into estradiol, it actually acts as a neuroprotective agent, and inhibiting aromatase enzyme activity with an aromatase inhibitor might actually cause deleterious effects on brain health. Now, this is only valid for testosterone's conversion into estradiol, right? Testosterone offers neuroprotection after it's been converted into estradiol. and taking an aromatase inhibitor would mitigate this effect. But taking an aromatase inhibitor would not prevent the conversion of trembolone into estradiol, or primobolan into estradiol, or winstrol into estradiol, because these compounds don't convert. So if you're taking trembolone or winstrol or other anabolic androgenic steroids, these will still cause excitotoxic neurodegradation and neuronal cell death, no matter if you take an aromatase inhibitor or not. Also keep in mind that dihydrotestosterone derivatives and many other compounds act as an aromatase inhibitor by reversely binding to the aromatase enzyme. So even if you don't take an aromatase inhibitor in the form of anastrozole, Arimidex, or letrozole, you might still get some sort of aromatase inhibiting effect from primobolan, or masterone, or nicotine, or diethylmethane, or chrysin, or grapeseed extract, or resveratrol, or zinc. Many different compounds out there can reduce aromatase enzyme activity or inhibit the conversion of testosterone into estradiol directly. So neurotoxicity might be an issue, but even if you don't take an aromatase inhibitor, this neurotoxicity of anabolic androgenic steroids might still manifest through different pathways. You know, it's also very neurotoxic, alcohol and some recreational drugs. So let's take a step back and compare daily use of 2 glasses of red wine containing resveratrol, which is supposedly beneficial for heart health, but as studies have shown, resveratrol can also inhibit aromatase enzyme activity, reducing the conversion of testosterone into estradiol, offering even less neuroprotection besides the alcohol, which is going to kill your brain cells left and right. Let's compare 2 glasses of red wine per day to daily use of testosterone and an aromatase inhibitor, albeit at therapeutic dosages, raising testosterone levels to somewhat out of the reference range and keeping serum estradiol levels towards the top of the reference range with intelligent use of an aromatase inhibitor. Again, this is in serum. The aromatase inhibitor will inhibit the conversion of testosterone into estradiol in the brain to a certain extent, increasing the potential for neurotoxicity. So does 2 glasses of alcohol potentiate some sort of neurotoxicity and inhibit the conversion of testosterone into estradiol with its resveratrol ingredient. Let's do both every day for 30 years. Let's take 2 groups of 1,000 people for an example. Which group has a higher IQ and is more successful, more cognitive by the end of these 30 years? I'll give you some food for thought. I know the answer based on anecdotal observations. I think the people who are drinking alcohol every day are cognitively impaired by the end of it, showing clear signs of neurodegradation over the group of therapeutic dosages of testosterone replacement therapy with intelligent use of an aromatase inhibitor. Food for thought, guys. I'll leave it at that. I don't think aromatase inhibitors are the devil. Ideally, you stick with aromasin. Again, the studies have shown that aromasin has the least impact on cardiovascular markers and the least impact on cardiovascular health with long-term use. This is in cases of breast cancer, not in cases where aromatase inhibitors, aromasin is used to keep estrogen favorable, in which case cardiovascular health should be sustained. Man, I'll leave it at that. This video is way longer, but I know you guys were getting bored with those shorts, so here's a very lengthy and long one for you guys. Vigorous crew, front double bicep for you guys. No aromatase inhibitors in these cannons, but I used to use them, and well, I'm still sitting here quite cognitive after many years of intelligent use of aromatase inhibitors, being aromasin. And yes, I've also used letrozole and Arimidex in the past. Have a look at the description section for everything that I'm associated with. My Linktree, my Instagram, my TikTok, my other YouTube channel, my websites where you can find my ebooks or how you can schedule consultations. It's all in the description section. Thank you guys so much for watching, and I'll see you in the next video.